The topic of my presentation today is generalized loss of lamina dura or follicular cortex on panoramic radiographs. In this presentation, I want to share with you several interesting cases showing generalized loss of lamina dura and or follicular cortex of tooth germs on panoramic radiographs and show what that means. Case A. A 9-year-old male complained of severe pain on mandibular molar teeth 5 weeks ago, and he visited a local dental clinic and panoramic radiograph was taken and NSAID and antibiotics were prescribed. He took NSAID and antibiotics, but the pain did not subside. So he was hospitalized at a medical hospital, but the results of CT scanning and blood test were unremarkable. Actually, this patient's father was a medical doctor of the medical hospital, and the colleagues tried to reveal the cause of the severe pain but failed. And then he was referred to our hospital, Seoul National University Dental Hospital, for further evaluation. This is the panoramic radiograph of the patient. What do you see on this panoramic radiograph? We can see disruption of lamina dura of first molars, and most importantly, we can see the destruction of follicular cortex, bony crypts of third molar tooth germ. Let's take a look at the CT images taken at the medical hospital. But unfortunately, upper third molar tooth germs were not covered by the CT scan. This area was not covered by the CT scan. This is the CT images taken at the medical hospital. Can you find any pathologic bone change in this CT image? We can see loss of lamina dura of the lower first molars. But there is no evidence of apparent pathologic bone change. Let's look at the CT images with soft tissue window on the right side. Can you see the high attenuation in the bone marrow space? Is this a normal finding? No. The bone marrow space should represent fat attenuation similar to that of the subcutaneous fat layer, but in this case, the bone marrow space, the attenuation of bone marrow space hardly increased. This is not normal. This is abnormal pathologic finding. We should consider normal pattern of age-related marrow conversion from red to yellow bone marrow. Bone marrow space of the mandibular body in a 9-year-old children. What does it look like on CT images? A study once reported on normal age-related conversion of bone marrow in the mandible using MRI, saying conversion of hematopoietic red to yellow fatty marrow occurred first in the mandibular body. I think further study on bone marrow conversion in the mandible using CT is needed, but empirically, we can say that the mandibular bone marrow space should represent fat attenuation. These are CT images from another 9-year-old male. we can see the dark low fat signal, fat attenuation in the bone marrow space. This dark attenuation is similar to that of the subcutaneous fat layer. So this fatty bone marrow space should represent dark fat attenuation. This is another example of CT images from a 9-year-old male. We can see dark, low fat attenuation in the bone marrow space. This is a normal finding. Let's come back to our case. We can see extensively increased attenuation in bone marrow space throughout the mandible. So this is a pathological finding. Although there was no apparent pathologic bone change, this bone marrow change is a very important pathologic finding in this case. So, extensively increased attenuation in bone marrow space indicates hematopoietic malignancy such as leukemia and Burkitt lymphoma. So, we did a critical value report to the surgeon in charge. Of course, marrow space infection or inflammation can also show increased attenuation, but it's relatively localized around an infection source. That's the differential point from hematopoietic malignancy. After we did a critical value report to the surgeon, post-contrast CT images were taken right away at our department. This is the CT image taken at our department. We can see the bone marrow space is replaced by high attenuation, and we can see disruption of follicular cortex of upper third molars and minimally enhancing lesions on both maxilla. And adenoid hyperplasia is also noted. So this patient was referred to the Department of Hemato-Oncology under the diagnosis of hematopoietic malignancy, and bone marrow biopsy was done, and the histopathologic result was acute lymphoblastic leukemia. In acute lymphoblastic leukemia, white blood cell counts at initial presentation can vary significantly. That's why the blood test of this patient had been unremarkable at the previous medical hospital. So, the radiologic manifestations such as change of bone marrow space, lamina dura, follicular cortex of tooth germs are very important. Early diagnosis and immediate chemotherapy are very important for better prognosis of the patients. In this case, although chemotherapy was performed, the patient expired 8 months later. So this is a case of undiagnosed hematopoietic malignancy. Let's move on to case B. A 30-year-old male presented with severe pain and burning sensation on the mandible and tooth mobility on lower molars. He had a history of endodontic treatment on this tooth 2 months ago at a local dental clinic, but the symptoms did not subside, and then he was referred to our hospital, to the Department of Endodontics. What do you see? What pathological findings do you see on this panoramic radiograph? generalized loss of lamina dura is noted and increased radiolucency around the periapical region of these teeth. This is periapical intraoral radiographs revealing generalized loss of lamina dura. Clinically, this patient was suspected of having osteomyelitis and then referred to the Department of Oral and Maxillofacial Surgery, and CT images were taken. On this CT image with bone window, there is no evidence of apparent pathologic bone destruction. However, we can see generalized loss of lamina dura. And on CT images with soft tissue window, the increased attenuation of the bone marrow space is well appreciated. So, the radiologic impression was hematopoietic malignancy, and we did a critical value report to the surgeon in charge, because on this patient's chart, the treatment plan was extracting molar teeth and trackage. He was referred to the department hemato-oncology under the tentative diagnosis of hematopoietic malignancy, and bone marrow biopsy was performed, and he was finally diagnosed with Burkitt lymphoma. Dentists can play a significant role for healthcare of patients with hematopoietic malignancy. The first clinical and radiologic manifestations may occur in the oral and maxillofacial region. So, hematopoietic malignancies can be suspected first by dentists. When we come across a suspected hematopoietic malignancy, we usually do critical value reporting. Here are such cases where we did a critical value reporting. A 15-year-old male with severe spray eruption and floating of molar teeth. He was not able to close his mouth because of the premature contact of the molars. The molar shows very severe spray eruption and floating. And of course, we can see generalized loss of lamina dura. This panoramic radiograph, taken just 1 month later after the chemotherapy, shows a significant remission of the lesion. Now he can close his mouth. Compare to this very significant remission after chemotherapy. Another patient, a 13-year-old male, presenting with pain and sudden increase in mobility on premolar and molar teeth. The onset was 1 month ago. What do you see on this panoramic radiograph? Yeah, we can see generalized loss of lamina dura, especially on premolar and molar regions, and disruption of follicular cortex, bony crypts of third molars. Intraoral radiographs also revealing generalized loss of lamina dura. Yeah, this case was acute lymphoblastic leukemia. Another patient, a 3-year-old male, presenting with gingival swelling and mobility on primary molar teeth. What pathological findings do you see on this panoramic radiograph? We can see loss of lamina dura on primary molar teeth and loss of follicular cortex of permanent first molars and primary molars. These are the CT images of the same patient. We can see minimally enhancing lesions occupying the bone marrow space of the maxilla and mandible, and also we can see the destruction of the maxilla and mandible. This was a Burkitt lymphoma. Another patient, a 43-year-old female. This was a case of martyr lymphoma. Martyr lymphoma is a form of lymphoma involving the mucosa-associated lymphoid tissue. But on this panoramic radiograph, the apparent loss of lamina dura is not demonstrated, but we can see widening of mental foramen on both sides of the mandible. And on CT images of the same patient, we can see extensively increased attenuation in the bone marrow space. And also we can see widening of mental foramen. So, through these radiologic findings, we could suspect the possibility of a hematopoietic malignancy, because this change in bone marrow space can be an important radiologic evidence for hematopoietic malignancy. Of course, differential diagnosis of lesions showing generalized loss of lamina dura include metabolic bone diseases such as hyperparathyroidism, renal osteodystrophy, osteoporosis, and so on. However, we should remember that on panoramic radiographs, especially of children and young adults, generalized loss of lamina dura and follicular cortex bony crypt of tooth germs can be the first sign of hematopoietic malignancy. Like this case, we can see generalized loss of lamina dura and disruption of follicular cortex of third molars. Thank you.